Hi, my name is Devyn and I'm a nursing student on 4A. I'm going to present a patient to you. Patient is a 21-year-old single Caucasian male. He is a current student at a Michigan college. Patient was presented to U of M on August 28th through September 9th, 2014 due to acute and progressive shoulder pain, left-sided weakness, and difficulty ambulating secondary to Klippel-Trenaunay Weber syndrome. Patient underwent an embolization on September 5th after an MRI at Sparrow Hospital showing evidence of vascular lesions causing spinal stenosis and possible compression. He was then discharged after improvement in right arm weakness. Patient then was readmitted to U of M ER on September 25th due to numbness and tingling chest down. On September 27th, patient underwent an embolization of the right ascending cervical artery. Patient was admitted to acute rehab and doing well until patient experienced neck pain and was found to be positive for Antibacter radiosistens. Patient was put on IV Zosyn due to an unclear infectious source. IV Zosyn was discontinued after blood cultures showed no growth. Patient underwent several angiograms on October 18th, including a right subclavian angiogram, right vertebral angiogram, and a left vertebral angiogram, as well as a puncture of the epidural space. On October 23rd, patient was neurologically stable and admitted to inpatient rehab for a prolonged decadron taper. Patient complained of worsening weakness in his left tricep, and an MRI showed spinal cord edema. Patient was then admitted to the neuro ICU. Currently, patient had no signs of infection and was then transferred to general care to work with PT and OT to manage neck pain and to manage his chief complaint, and await surgery on November 21st to decompress the mass found in his spine. Vital signs are stable according to his baseline. Blood pressure 160/85, this is a normal finding. Pulse 54, respiration 16, temperature 36.6 degrees Celsius taken orally, and oxygen 96% on room air. Past medical history includes Klippel-Trenaunay Weber syndrome and asthma. All immunizations are up to date. Patient is allergic to non-steroidal anti-inflammatory medications, aspirin and ibuprofen. Past surgical history includes a right shoulder disarticulation in 2002, a left transtibial amputation in 2007, and a splenectomy. Patient is on oral vitamin D3 2,000 units daily, oral Senna daily, oral Tylenol 500 milligrams, PRN Q4, oral Decadron 4 milligrams, orally Q6, and sub-Q heparin 5,000 units 3 times a day. Functional assessment. Patient denies alcohol, tobacco, and illicit drug use and has no signs of sleep disturbances. Patient has no current exercise regimen. Patient states he eats healthy but sometimes refrains from eating breakfast and enjoys drinking coffee and pop. Patient has a power wheelchair for long distances but can wear his prosthetic leg for short distances. Psychological data. Prior to hospitalization, patient was living in a dorm at school located in Lansing. When discharged, patient will go home with his mother, who resides in a one-floor wheelchair-accessible house. Patient has a younger twin brother, an older brother, and an older sister. Patient states he has a good family dynamic and no perceived stressors. Patient practices religion and identifies himself as a Christian. Patient states he has no family medical history. Neurological. It is important to assess patient's neurological status every 4 hours due to prior complaints of numbness and tingling. Patient has in the past complained of faint numbness and tingling from his chest down. Patient describes loss of sensation in a distribution below C7 on his spine. Patient also describes left upper arm weakness. He denies seizures, loss of consciousness, concerns about memory loss, sleep disturbances, anxiety, and difficulties with speech. Upon physical examination, patient is sitting up in bed with no acute distress. He is a well-groomed young male and is alert and oriented person, place, time, and situation. Speech and vocabulary are clear. Pupils are equal round and reactive to light and are 3 millimeters, and extraocular movement is undamaged. Glasgow Coma Scale is 15. Patient has difficulty deciphering between soft and pain sensations on upper left arm and right lower leg. Patient is able to decipher between soft and pain sensations on all other testable extremities. Patient has a normal Babinski and ankle clonus reaction. Unable to test cortical and discriminatory sensation due to amputation of right arm and lack of grip in left arm. Unable to assess gross motor function due to amputation of left lower leg. Patient has good fine motor movements. Patient passed all questions presented in the mini mental exam, including serial 7s, ability to remember 3 objects, testing his long and short-term memory, and his judgment. Integument. An integument assessment is important for patient due to skin impairments resulting from Klippel-Trenaunay Weber syndrome. Patient reports no extreme dryness, itching, or flaking on any extremity and scalp. Patient is aware of port wine stains but reports no change in hair distribution and growth and no change in nail contour, thickness, and color. Patient denies any new skin issues that isn't already aware of. Upon physical examination, patient is clean, no perspiration, and no body odor present. Scalp appears clean with no flaking or lesions. Hair on scalp and body is evenly distributed, and color, amount, and texture are normal for patient's age. At testable areas, patient's skin tone is normal for race and age. Patient has good skin turgor. Patient's testable nails present good capillary refill, normal thickness, shape, attachment, contour, and good hygiene. Patient has port wine stains due to Klippel-Trenaunay Weber syndrome on abdomen, left stump, back, and buttock. The port wine stains appear a purplish maculopapular rash, but again, this is baseline. Patient's stump appears more purplish than rest and is mildly warm to touch. Patient presents with multiple scars on abdomen. There is gross swelling with partial clubbing of left hand. On inspecting of the buttock, patient presented with weeping bright red blood at some sites of port wine stains. ABD pads were applied to absorb blood. Patient's Braden score is 18. Pertinent system number 1. A peripheral vascular assessment would be applicable to this patient. According to the Open Access Journal of Plastic Surgery, Klippel-Trenaunay syndrome is a rare genetic disease that is characterized by 3 malformations, one of them being vascular anomalies, more specifically low arteriovenous malformations and varicose veins. A peripheral vascular assessment is also pertinent due to common symptoms including deep vein thrombosis and pulmonary embolisms. It is important to note these vascular malformations can arise on internal organs, so inspecting for major bleeds is vital. Due to patients' long stay in hospital, it is important to make sure physical therapy techs and nurses are working with patient to keep extremities moving and blood flowing to avoid DVTs and pulmonary embolisms. Assessing the peripheral vascular system for edema, warmth, abnormal loss of hair on extremities, pain on extremities, presence of varicose veins, and administration of anticoagulants can help identify and prevent these complications from arising. Pertinent system number 2. Due to the vascular abnormalities, a musculoskeletal assessment would be vital for this patient. According to seminars in pediatric surgery, Klippel-Trenaunay syndrome can cause leg length discrepancy, lesions on muscles, and functional limitations. In this case, patient required surgical intervention due to limb overgrowth leading to amputation of right arm, lower left leg, and 4th and 5th digits on left hand. It is often done when patient is younger to minimize parasitic limbs. This is evidenced by patient's amputation of limbs at age 9 and 14. A musculoskeletal assessment is pertinent to assess for decline in muscle strength, joint pain, redness, warmth, limitations in range of motion, and limitations in daily activities. Patient goal is to improve functional impairment to eventually be discharged to mother. Therefore, if musculoskeletal assessment is performed as well as range of motion, physical therapy can work with patient to improve functional abilities and work toward a possible discharge. If a musculoskeletal assessment finds decline in muscle function, patient's physician and work toward a rationale as to why and if further treatment is needed.